So I'm going to tell you about the stage 1 assessment process, about how your trainee is going to need to prepare, what they can expect on the day, what happens after the assessment. And I'm going to do this by telling you about the role of the assessor. And along the way, I'll try and tell you a little bit about how we make sure the scheme's as fair and equitable as we possibly can. So, first of all, I'll tell you a bit about the assessors. So we're all either experienced examiners or supervisors or both. And we've all been recruited against national standards. So what do these people do? Well, as I said, we're assessing competence, aren't we? And we're assessing the elements of competence that the GSC have put together. And we do that against an agreed standard. So the idea is that to make us all assess the same way, we've got agreed standards that we're trying to judge people against. And that standard has been agreed by the whole examiner and assessor population together. And then those standards are reinforced every time we get together. So we have annual assessor examiner training, and we have regional peer groups that are designed to reinforce these standards as well. So in this way, what we're trying to do is ensure that every assessor, given the same evidence, would make the same decision every time. So how does your trainee prepare? Okay. So first thing about preparation is it's about collecting the evidence in a usable format. And it starts off with a logbook. And the logbook, page of the logbook looks a bit like that. It's a list of all the patients that the trainee sees. Site test patients, there's a dispensing log as well. There's space for them to write presbyope, pre-presbyope, age of the kiddie, if they've got something wrong with them, are they a contact lens fit or aftercare, they've got a BV anomaly, you've used drugs on them, they're a low vision patient. So this is useful to the trainee, very useful to the trainee, because first of all, it's how they prove they've done the numbers, their 350 tests and their 250 dispenses. So that's quite important. It's also very useful to record the cases that you want to show the assessor. So they've got a patient episode they need to show us, the AMD patient, for example. So if Mr. Smith was an AMD patient, you write AMD in big letters there, so you can find the record to show your assessor. It does help them plan their workload, and help you plan their workload. So if once a month the trainee gets these all added up, after a couple of months in practice, if you find that you look at this together and they've done no kiddies and no contact lens experience, you've got a problem, but at least you can sort it out because you've identified the problem. It also helps the trainee provide evidence of a range of experience. The wider range they get, the better, and it makes us assessors feel more confident that they will be competent if they're getting a range of experience. Useful for the assessor, because I need to check numbers, and it's check the veracity of the evidence. So if they show me a record of an AMD patient, lovely. Is it in your logbook? If it is, I'm probably a bit more confident it's genuine and not made up. So also within their handbook, counted as logbook evidence, there are various other things that help in terms of preparation. So the first one is the monthly training review, which looks a bit like this. So this would be for visit 2, so the second visit of the stage 1 of the work-based assessment. List of all the elements of competence that we're assessing at that visit, and then a box for you to write from 0 to 3, are they had no experience, can't do anything at all, to 3, they're completely competent, they can do it on their own basically. So when you signed your supervisor undertaking, you undertook to do this once a month with your trainee, to sit down and review them. Really useful for the trainee, again, in lots of ways. First way is it's a chance to get your feedback. Hopefully in a structured and useful format. It helps them target their study, their plan, their workload. So if they know they're a grade 0, grade 1, they obviously got to target that. Find some evidence, find some experience, do some book work. And it also helps them, this is a big one, helps them prepare for their assessment visit with their assessor. So if they think they're a grade 3 and entailing relevant history and information, brilliant. Where's the evidence? What record can they show you that evidence is that? What have you seen them doing that they can remind you about that evidence is that competence, that element of competence? If they can prove it to you, they can probably prove it to me. And by getting that evidence out, they've helped themselves prepare for the assessment. So it's really good practice. So also within logbook, there's space for personal reflection. It's not something I routinely look at, but the trainee's got some paperwork in there to think, well, I've learnt this, I've learnt that, what do I need to do better? If they want to use it, that's fine. So quarterly summary, So it looks like that. So this is the addition of all the separate logbook pages. So once a quarter, it's good practice to add them up. There's a monthly summary as well. You can add the monthly ones up to make the quarterly one. Really useful for me, and we'll talk about how I use that in terms of preparation later on. And then the other thing that's in the logbook, it is really important, patient episode sheets. So we talked about some of the elements of competency, in fact most of the elements of competence, needing a compulsory patient episode alongside them. So for each visit, visits 1, 2, 3, there is a patient episode sheet which lists the compulsory patient episodes for that visit. Okay? So what your trainee needs to do is to find a name or a number to go in each of these boxes. And then these are the records that the assessor will look at when they come to do the assessment visit. So in lots of ways, your trainee is setting up their own assessment visit by the records they pick. So in terms of preparation, you can see then that by the time we come along to the assessment visit, your trainees got a lot of evidence already. They've got evidence of range of experience, evidence of numbers, they've got the patient episode sheet, they've got your review, it's useful as evidence. So that's a start. And also they've helped prepare themselves for the assessment by getting the records out and thinking about what they're doing, by planning and preparing for your reviews with them. If we go back to the timeline, you remember that stage 1 of the work-based assessment, which you're talking about, is going to have probably 4 visits in. Possible to do it in 3, most likely 4. And as part of ensuring that each assessor works in the same way, just assesses the same standards, each of these visits is going to have a standard, certainly each of the first 3 visits will have a standard visit format, which we'll talk about now. And that will tell us where the direct observation elements fit in. So let's just touch on that now, and this will begin to tell you about what's going to happen on the day. So, as I say, there's a standard assessment plan for each of these first 3 visits. Your trainees got their assessment plan for visit 1 already because they got it at the university roadshows. And it tells them which compulsory evidence we're going to look at on the day, and it talks to them about the secondary evidence that's needed. And when we get to visits 2 and 3s, it'll also talk to them about some of the action plan that's gone on for competencies they missed the first time round. So, if we think about visit 1, this is the start of the assessment plan for visit 1. Okay, so this is a month into their practice life with you. 10 competencies. You're going to have a dummy patient for them to play with, so a member of staff, friend, whatever. And they're going to do characterometry and pupil assessment and a tear film assessment on that patient. And then they're going to do verification of a pair of specs, which we'll bring along, usually a pair of multifocals. We've got 10 minutes to complete the task. You would be amazed how long it takes some trainees to do this. And then they're going to provide us with at least 3 records. So we're going to have a record of a contact lens teach, record of a pupil assessment, which could be a normal pupil assessment, and a record of a patient showing any risk factor for any common ocular condition. So you can see we're beginning to collect evidence. We've got direct observation, we've got record card evidence, and then we're going to back that up with structured questioning around their records, exploring their knowledge, and then we may use other forms of evidence if we need them, and I'm going to come back to that in just a bit. So we've got a 2-hour assessment. This is probably going to take about an hour, maybe a little bit more, hour and a quarter perhaps, but about an hour. Depends a bit on the trainee. The rest of the time is going to be spent doing this. So we're going to pick out 3 records from their logbook, and we do that to check that their logbooks actually work and they're writing things in the right boxes, and to tell them they can photocopy the pages. And we're going to talk to them about the record keeping for those 3 records, because records are really key. We look at a lot of records, we spend a long time looking at records, and if their skills aren't good at writing records, then they're going to really struggle. Particularly things they miss out is advice. So if it's not written down, they didn't say it to the patient. It's as simple as that. So record keeping we check. And then we're going to spend half an hour, maybe 3/4 an hour, with you and the trainee together, checking your understanding of the process, answering any questions, and agreeing the assessment dates for the rest of the assessment visits. Ideally, we're going to book all 4 visits, or the remaining 3 visits on that date. And we're obviously going to give you feedback from the assessment visit that day. So what went well, what didn't go well, what actions do we need to take to address the weaker areas. And the assessment plan for visit 2 looks like that. But before we get to that, the action plan will request some information from the trainee. So before I come and see the trainee for visit 2, I will have had various things from the trainee. I'll have had the quarterly training summaries. We talked about that in the addition of the logbook pages, so I know where they're at. I'll have your latest review of them. So by the time I come for visit 2, there'll be certainly 2, but probably 3 of those appraisals. I just want the last one. And then the patient episode sheet. So I'll have all those posted to me ahead of time or emailed. This really helps me plan the assessment. So if I get a quarterly training summary for visit 2 with 20 site tests on it, well, I'm not coming to visit because it's way too low. It should be around the 80 mark. And the trainee won't get through. There's no point. It's a waste of time. Equally, if your appraisal comes through and it's all 0s and 1s, again, there's no point in putting the trainee through it because they're not going to do very well. So we'll rearrange it. But if they arrive saying, we've got a patient episode sheet with lots of records on it, but we've got no contact lens experience, well, fine, not a problem. Let's do the assessment, but I'll ring the trainee up and say, look, you're not going to get through the contact lens bit. There's no point doing an aftercare because you've had no experience. What can we do instead to fill that time? Have you got anything for visit 3 we could pull forward? Ideally, I'd like the trainee to have already done that, to have thought about it and said, look, I can't do these competencies, these elements. I'll do something else instead. But I'll try and make it happen. So they are really useful if we get them in time. We request them 2 weeks ahead. So then this is what visit 2 looks like. So real patients, they're going to do a real site test on a real presbyope out of your clinic or out of your practice. So it could be anybody who walks in, anybody who got booked in the diary, that's fine, it's not a problem, as long as they're a presbyope. And they're going to do a soft lens aftercare again on a real patient, so a real member of the public. And that will cover off their slit lamp assessment observation as well. And then they can have a dummy patient, again, friend or a member of staff or somebody, willing victim, who then do Volcon. And that can be dilated or undilated. If they choose to do Volc in their routine, that's okay, they can do direct on this patient, whatever. So this is going to take a good training, hour and 45. So hour and 3/4, 2 hours, practical stuff's out the way. We've then got an hour and a half, maybe a bit more, looking at other evidence. So we're going to try and back up our practical observation with patient records. So yes, I've seen them do this. Do they do it every time? Lovely. If they do, that's great. And then if I haven't got enough evidence from the patient records and witness testimonies, then I may well then step into using other evidence. So I might present them as photographs and say, tell me about that. Case scenario. So this is wet AMD. What if it was dry AMD? Da, 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 da. We could do role play if we wanted to explore history taking. We could do prescription interpretation, perhaps give them a prescription to look at and say, tell me about that one. There's all sorts of different things we can do. But the strongest forms of evidence, these things, certainly direct observation and then the record cards are the definite strongest. And that's visit 2. Visit 3 then looks like this. So again, a real patient for an RGP lens aftercare. Okay? But real in this situation means someone it's appropriate to do the aftercare on. So if they fitted a friend or a member of staff a week ago, they've worn the lenses all week, well, it would be appropriate to do aftercare on that patient, wouldn't it? Well, that's okay. No problems with that. I have a problem with trainees who stick a pair of lenses in somebody's eyes 20 minutes before I arrive and try and do an aftercare. Well, there's no history, there's no decent fit result because the lens is going all over the place. There's no decent reaction to the contact lens. It's not worth doing. So it's a real patient. Okay, so real RGP aftercare. Dummy patient, then soft lens fitted in one eye, RGP fitted in the other. Contact telemetry as well on that patient. And then again, we're on to the other evidence there. So just to give you an idea of how this might work on the day then. So 1.1.1, That's the element of competence there. So I'm going to see the trainee do a sight test and a contact lens aftercare in visit 2. So I've got direct observation evidence. And then I'm going to look at the patient records and I will get further evidence from all those records. And actually, with just those 2, I might not do anything more. I might have enough evidence from that. If I need something else, then maybe I'll come up with a case scenario. So what if you heard this in the history? Or I might look for other evidence in other ways. So for an example then, how about this one? So we have 3.1.5, which is investigating fields. The question is, how would I get that evidence? So are they going to show me a record where they've done it? Maybe when I see them do a sight test, they've got a patient that would be appropriate to do that AMSLA on. Well, I've now got direct observation evidence as well. I might question about it. I might come up with a case scenario. So if you had a patient with central scotoma, how would you deal with that patient? Okay, so case scenario might be another form of evidence. The one we all use for this one, I think, is field plots. We take along field plots as well. So what we're saying to you is there's all sorts of different evidence that we could use to assess this competence. And what we try and get our trainees to do is to think about what evidence they're going to show us. So again, they will drive it. So ideally, we get to this, and I'll say to the trainee, okay, so we're going to look at investigating visual fields. What evidence you got for me? And they'll pull out a record card and this record card, and I say, well, I did this over here at the hospital as well. I got this listed, and it's brilliant, lovely. It's all done and dusted. There you are, job done. When you say to them, what evidence you got, and they go, I don't know, then it gets more difficult. And again, that slows the process down when you're trying to force them to find the evidence. So second one, so dispense the range of lens forms to include complex lenses. So again, I have to get patient record evidence. If you're supervising this trainee, then hopefully, certainly when I was supervising, I saw every single record card. They brought it to me and I would look at it and sign the prescription before they left the practice. And when they came and did that, I might say, okay, so this was an ESO, so what if it was an EXO? And make them think then and there. It doesn't always work in terms of time, but even if you think, okay, I want to ask them about that later on, and you get 5 minutes at the end of the day and do that to them about their records that day, or maybe you could find half an hour at the end of the day and sit down with all their tests they've done that day and run through the records and say, so what about this? Da, 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 da. That would be really useful. That would make more difference to them than ramming through loads and loads of tests that they do okay but not great. So now comes the tough part for the assessor, because they've got to decide for each of the elements of competency, has your trainee achieved, not achieved, or easily not been assessed on that competence. Once we've made that judgment, then we'll move into feedback and action planning. So yes, you need to be available for this. So what I would normally do in my action plan, which I'll send to your trainee a month before I come, is say, this is what we're going to look at, these are the timings, and the last half hour I need you and your supervisor together in the room, and we'll talk through the feedback. But whatever we do in terms of a plan, we'll try and make it clear in the plan, this is what went wrong, this is what you need to do to address it, and this is how I'm going to reassess it. So once we've agreed the action plans, then I'm going to leave the practice and I'm going to go away and write up the assessment report. Your trainee's going to go away and faint, but I'll go away and write up the assessment report. And it's all done online, and it's going to arrive with you and your trainee within the next week. So the report looks like that. This is the first sheet of it, and you can see it's listed all the competencies that were due to be assessed, achieved, not achieved, and if they're not assessed. And then there will also be a little summary at the end, which I haven't got a copy of, where kind of additional comments are made by the assessor. And I would often use that to try and set up the next assessment visit. So these are the things you need to be aware of for next time through. And that will kind of almost be the start of their assessment plan for the next visit, but I'll get them a copy of the assessment plan before I come along next time. Part of the way that we make sure we're all doing the same thing is that 75% of the assessors are also college examiners. So you do get a lot of feedback on your performance as an examiner, and also as an examiner group you're together fairly regularly, so you can trade ideas and judge yourself against your peers. So that's really useful. Also, every assessment we do, we send a report in, and the statistics on that report are collated against us. So we very soon learn if we are very hard on this particular element of competence or very soft on this one. And we're judged against our peers to try and get us all working to the same level. So we do get that feedback regularly, and it is really useful. On top of that, all the assessors get visited. So just thing to leave you with is that we're nice people, honest. We're not there to come and pick on you. We're certainly not there to come and pick on your trainee.